Hello, everybody, and welcome to this BTOG ESMO Top 10. My name is Tom Newsom-Davis. I'm a medical oncologist based at Chelsea and Westminster Hospital in London, and I'm the chair of the BTOG Steering Committee. And I'm absolutely delighted to be joined today by two of my medical oncology colleagues in this review of the top 10 abstracts and data presented at the ESMO 2025 meeting just last week, focusing, of course, on all things lung cancer. I have Shobhit Baijal, who is a medical oncologist in Birmingham, and Sharmistha Ghosh, who is a medical oncologist at Guy's and St Thomas's in London. Now, there's a slight change to what we're doing. Those of you who are loyal listeners, and thank you for being loyal listeners, will know that for a few years now we've run ASCO in an hour and ESMO in an hour. And we've done that as a webinar. We've had a live presentation, and you can either dial in live or you can catch up on the BTOG website. And that's been really, really successful. But give me a minute or so just to explain why we're slightly changing things. What we've noticed over time is that not only is the webinar catch up popular, but the podcasts are becoming really, really popular. The podcast recordings of this. And so I want to change it in such a way to make it even easier to access on podcast. The other thing is that podcasts themselves are changing, and video is coming into podcasts and is now a feature of many podcasts, depending where you download it. So the way this is going to work is that I've got 10 top abstracts, and the three of us are going to discuss them. The first five in a little bit of detail, and the next five in very superficially. There are some slides, there are about 15 or 17 slides in the entire thing, and we'll tell you when they're up. And if you can access the video aspect of your podcast, then please do so. If you're wondering what on earth a video podcast is, then platforms such as Spotify will allow you to see the images as well as the audio. Some other podcast download sites, for example, those on Apple, perhaps don't do. So without further ado, we're going to move on with our new format. I hope it works well. And I hope whether you're listening to us on podcast, watching us on podcast, or downloading us on the BTOG website, that you really enjoy the next 40 minutes or so. So as promised, and as you can see on my screen here, the first big five we're going to talk about are these: OptiTrop Lung 04, Harmony 6, the Delphi 303 study, North Star, and MDT Bridge. And these are all studies which I think are going to have impacts on what we do either today or in the near future. Now, the first one we're going to focus on is OptiTrop Lung 04, and that's important because it's the arrival of antibody drug conjugates, and we've seen a few of these coming through. This is targeting TROP2, but what's really interesting about this study in the second line EGFR mutated lung cancer is with this almost second generation ADC, maybe something that works. So Shobs, I'm going to pick on you first. I wonder whether, as I show the audience the study design, could you tell us a little bit about why this study is designed as it is, and maybe the setting in which it's used?
Yeah, thank you, Tom. So, as you've put up on the screen, so we've got the OptiTrop Lung 04 study designs. This is a phase 3 multi-center randomized open label clinical trial, but run only in China. So patients had to have advanced metastatic EGFR mutated lung cancer, one of the sensitizing mutations, and had to progress either on a first or second generation TKI, but not having acquired the T790M mutation, or a third generation TKI. So I think that's quite an important point to focus on, that these were not all post third generation TKIs we would expect. Patients were randomized 1-to-1 to receive this new TROP2 ADC, sac-TMT, at 5 milligrams per kilogram, Q2 weekly, against standard of care, which was platinum pemetrexed chemotherapy, for up to 4 cycles, and then moving on to maintenance pemetrexed.
Yeah, so what I like about this, just to jump in, is that actually you're right, it doesn't maybe include all of our patients, but it does really reflect largely the post TKI patient group. Um, Can you tell us a little bit about the efficacy data, which was presented at ESMO?
Yeah, so in terms of the primary endpoint, that was progression-free survival by BICR, and there was actually quite an impressive improvement in PFS, almost a doubling from around 4.5 to close to 9 months in terms of median progression-free survival. Objective response rate, again, quite impressive, about 60% for
Mhm.
the
Yeah,
experimental arm versus around 40%. And then overall survival at this interim analysis, which we can now see on the screen. Again, median not reached for SAC-TMT, and 17.4 months for chemotherapy. And this is giving a hazard ratio of 0.606, which is statistically significant at this point. So, and I think at that 18-month landmark, 65.8% in the SAC-TMT arm versus 48% in the chemo arm. So I think this on face value at the moment is, to me, from an efficacy perspective, quite impressive data and definitely showing activity for this ADC.
I agree. In fact, if people can see the images, you'll see that those OS curves separate pretty early on. And that the data is immature. We need a bit more, but it's certainly that OS positivity in this study is certainly eye-catching. What about toxicity? So the ADCs, some of the earlier ones have been troubled by significant toxicity. Certainly some of the MET antibodies, ADCs, sorry, certainly are. What do you think about the toxicity profile with this agent?
Yeah, so most of the toxicity, or there were treatment-related AEs, both arms. Most of it was what you'd expect from the cytotoxic component, so really hematologically focused. The more severe TRAEs were really in the platinum pemetrexed arm, showing that SAC-TMT was potentially a safer agent. It does bring in the novel ADC toxicities that we do need to get our heads around. So stomatitis was more prevalent, although of low grade. And ocular toxicities around 10% of patients. As we can see on the screen, we've got the AEs showing here. 9.6%, but low grade again. Interestingly, no ILD or pneumonitis, which has been um, a treatment-related AE of interest in terms of ADC. So that was interesting to see, especially in this population.
So, Sharmistha, what's your take on this? At the moment, post TKIs, we are in the NHS using pemetrexed and carboplatin, our old faithful. We've seen Mariposa 2, which, to remind people, is Pem, Carbo, and amivantamab having a proven in studies recently. Um, is this ready for the big time? If this was available in your clinic, would you use it? Do you need more data to convince you? What's your thoughts?
Yeah, a little bit more data, just a bit more mature data would be useful. But I certainly sat up when I saw this. It reminded me when Shobhit there mentioned the comparator arm, the chemotherapy, the control arm, 4 months is what we're seeing in our patients. 4.3 months it is. There's a real unmet need here for this group of patients. They do really well on their TKIs for a length of time, a year or so, and then we really don't have much. So I was really excited to see this. This is a new agent for
Yeah,
EGFR
I agree.
cancers, ADCs. So, and as Shobhit said, almost doubling. So we're almost hitting a year. So I was actually quite excited at this. And then I was, further reassured when I saw that, yeah, the adverse events is nothing really that we're surprised about. Have to get used to the stomatitis,
Yeah.
kind of, but low grade stomatitis. So I was reassured and quite excited.
And Shobes, you mentioned it's only a Chinese population. There is a global phase three going on. Are we being unfair in looking at a Chinese population and saying this doesn't apply to us, or do you agree that we do need global data before we can use this outside of China?
I think it's always useful to get an heterogeneous population.
Yeah.
And also on top of that, I think also the regulators, it works in look for that. So I think it's reasonable. And as you said, there is a global phase three underway. And I think also, I totally agree with Shamist. I think we want more mature data. I think there are other strategies that are being explored, continuing the osimertinib, as in tropion lung 15. So I think that this is an area, I think I think it's reassuring both from the earlier tropion studies, which showed definitely a signal in the AGA population with TROP2 ADCs. This seems to confirm that signal. But I think, yeah, I think we definitely need more mature data, more global data, and I think maybe a look at combination therapies as well.
Yeah. I agree with both of you. I thought this was really interesting. We do need confirmation. I would like to have known a bit more about activity in the brain. That's a big issue for CNS disease. I felt that the adverse events, which you can see on the screen now, are more favorable, really, than the Mariposa 2 combination. And we know that when someone's coming off osimertinib, they've had a probably very low grade side effects for quite a long time, and the prospect of toxic treatments are challenging. So we really look forward to seeing that global phase 3. We're going to move on to our next study, which is called Harmony 6. And Harmony 6 is a really interesting study because it involves a drug called ivonescimab, which is an antibody targeting two things, PD-1 and VEGF. And it's been going around a little bit recently with data coming out at World Lung and also data in ASCO earlier this year and indeed profiled the year before. The Harmony 6 is looking at squamous cell tumors. And I wonder, Sharmistha, if you could tell us a little bit about the study design of this and where it was undertaken.
So this is a trial looking at just squamous cell lung cancers, as you said, so no adenos. And we're looking at patients with advanced disease, so metastatic cancer, completely treatment naive in the metastatic setting. And they've quite rightly excluded kind of any EGFR ALK rearrangements, which we wouldn't necessarily expect in squames, but just to set that straight, and with a relatively good performance status. So patients were randomized to receive this medication, ivonescimab, which is a bispecific PD-1 and anti-VEGF with a platinum backbone, so carboplatin and paclitaxel, which is a good treatment choice for first-line squamous cell lung cancers. And that was in comparison to a PD-1 inhibitor, so tislelizumab, and the same platinum backbone chemotherapy. And they had 4 cycles of this treatment, as we would usually with chemo IO, and then a maintenance of IO, or if you're in the ivonescimab arm, the IO with the PD-1 and the anti-VEGF. So
just to jump in there quickly, the reason to explain to people why tislelizumab was used is that's standard of care in China.
Yes.
And so there's not something which we currently use out in UK. I don't think people should see that as a negative. It's just the one that they use.
In my head, I was thinking pembrolizumab, that's the kind of what
I
they
think that's
use
very
and we use here, kind of pembrolizumab. So when I saw this come out, I just kind of imagined pembrolizumab, carbotaxol. I know they're not the same drug, but it's a similar and similar same population of patients. So we're basically looking at chemo IO versus chemo IO and anti-VEGF. Kind of like a chemo carbotaxol, atezo and bev, kind of you're adding in the anti-VEGF there.
And that's really interesting because traditionally we've not used VEGF inhibitors in squamous cell tumors. There's always been a concern about bleeding and necrosis. So maybe get onto that in a second. But what about the efficacy data? Were you excited by what came out of this, Sharmistha?
I was again. So if we look here, so the blue line here, for those who can see this, is the ivonescimab and chemo arm, and the red line is the chemo IO arm. And we can see that the Kaplan-Meier's are separating quite early on. And the median PFS for the ivonescimab chemo arm is 11.1 months. So we're nearly hitting a year here in comparison to 7 months, which is what we would expect for chemo IO, squamous cell lung cancer. So kind of confirms this is a similar group of patients that we're seeing. And we're seeing almost doubling, so a year here with the addition of the anti-VEGF. So for me, I was, again, very excited, interested to see where we could go with adding in the VEGF here as well.
And I think the other very interesting thing about that PFS benefit, which I agree is interesting, is it appeared to be regardless of PD-L1 status. And this is a difficult treat population. I'm afraid patients with squamous tumors don't do as well. And to have something which may be equally beneficial in people with a lower PD-L1 is obviously very welcome.
When we looked at the subgroups, I don't know if you've got the subgroup slide, but those patients who were with lower PD-L1 actually did very well. And the hazard ratio was lower with the ivonescimab as well. So for those patients in whom, with the lower PD-L1, you're struggling, the addition of this anti-VEGF is clearly having a benefit here. So that was very interesting.
Yeah, absolutely. I think that's really key.
Looking here at the safety, the one thing I did was a little bit concerned about was, in my opinion, the grade 3 kind of adverse events is quite high. So over 60%, almost two-thirds of patients in the ivonescimab arm did have a grade 3 adverse event. So in my mind, that was a little bit higher. At 50%, just over half in the chemo IO arm with a grade 3 toxicity, which I don't know what you two feel, but that's probably a bit higher than what I would experience with my chemo IO patients here. But, you know,
I think
yeah.
it's a bit higher, and it's mainly heme tox, isn't it? Mainly neutropenia, leukopenia, platelets, but it does seem to be higher. What do you reckon, Shapes?
Yeah, it does. It does. And I think I'm sure you're going to go on to it now. Is more interesting is the kind of the VEGF focused toxins as well.
The
Yeah,
VEGF ones, the hypertension, proteinuria, as we would expect, were reported, but they weren't necessarily the grade 3 ones. So not necessarily the addition of the anti-VEGF component wasn't necessarily making the or causing the AE rate or more significant.
yeah.
So whether it's the that's my point. The chemo in the IO arm alone is still a little bit higher than maybe what we'd expect here. Maybe they're not using GCSF with their treatments like maybe we are more prone to using. That's something
Yeah.
we look into.
So I think there's some really interesting data here. We have the same caveats. This is a China-only study. It does need global verification. The increase in progression-free survival is impressive. It tells us, although there is a slight increase in the side effects here, there are no concerning ones regarding hemoptysis or those kind of things. So it does say VEGF is safe in squamous tumors. Um, Shobes, one of the criticisms of VEGF inhibitors and of ivonescimab in a presentation at World Lung a couple of months ago is, yeah, you get a PFS benefit, but it never translates to overall survival. Now, we don't have overall survival yet for this study. Um, is that a concern for you, or do you think when you've got a PD-1 VEGF inhibitor, we need to look at things afresh and just wait for that OS data? And are you optimistic it might be positive?
I'm optimistic, but I think we have been bitten already by VEGF, not just in terms of this agent, but if we look at the IMPALE study, those once we get to OS, the hazard ratio and the confidence interval will start to look less impressive. So whether there is something in VEGF in terms of resistance pathways, I'm not sure. I think the PFS here is pretty impressive, but I think I would like to see that OS benefit. We have been caught out in this class of drugs before.
Yeah,
And I think
I
there probably was an element of I think this was coined as quite safe, but I think there were a reasonable number of hemorrhages which um, were I think low grade overall, but I still think we probably need to put some caution when using this class of drugs if they do come through in the squamous population. I think I
yeah,
agree there
I
were
think you're
small
absolutely right.
numbers, but
I think you have to be cautious. And I lost track of the number of times people use the expression manageable safety profile. I mean, anything's manageable, but I think you're right. I think we need some granularity on that. So, Shob's going to stick with you, and we're going to go on to the Delphi 303 study. So, just to explain to people, this is in the small cell patient population. It's with tarlatamab. It's a phase 1b study, but I think it's a really important study. And Shobs, could you tell us a little bit about this phase 1b study, and then we'll get on to some data on the effectiveness?
Yeah, so thanks, Tom. So this is kind of the trial that keeps giving. So it has multiple different parts or components to it. So we've already had, I think, earlier this year, the maintenance phases looked at, but this is now really pushing tarlatamab further up the algorithm in terms of actually using it up front in combination with our chemotherapy, immunotherapy for our advanced extensive stage small cell lung cancer patients. So I think it's quite a pragmatic design in that patients were allowed to have one cycle of chemo IO prior to, because of the complexities and logistics of delivering tarlatamab, at least for the induction period. So we're allowed to have one cycle of platinum IO. And this was different components of the IO. This had an atezolizumab component or portion, as well as durvalumab. So it wasn't really looking at the difference between those two agents, but really just showing the safety of and efficacy of combining tarlatamab to them. So patients had From cycle 1 to 3, they had tarlatamab combined with their platinum chemotherapy and PDL1 anti-PDL1 agent, and then they would move on to maintenance with tarlatamab and anti-PDL1. So the primary endpoints really focused here on safety, but we do also have secondary endpoints looking at efficacy.
Absolutely. And what I probably should have said when I started was that tarlatamab is a bispecific T cell engager focusing on DLL3. So, yeah, this is really interesting. And of course, being a phase 1b study, it is all about focusing on toxicities, but there was some data on effectiveness. We'll focus on adverse events first because it's a phase 1 study. We know that there are some complexities of tarlatamab regarding cytokine release syndrome and other immune-mediated side effects, something called ICANS. What did you think about the overall toxicity? That's non-comparative, Shobes. This is not against anything else, but what did you think of the general adverse event profile?
Yeah, so there were treatment-related AEs, quite a reasonable number in terms of grade 3 or more, but most of that was really focused on the chemotherapy component that
Yeah.
we would anticipate and expect. So the ones of interest or the novel ones that, and again, fair to say that we didn't see any high signals of immune-related toxicities, but really focusing on the novel ones that the bispecific brings, which is ICANS and CRS. So again, CRS was really focused on that first cycle and relatively low grade. We didn't see many beyond cycle 1 of treatment. And ICANS was actually exceptionally rare, and very few patients discontinued treatment from those two related AEs. So I think from a safety perspective, this really does seem deliverable. Taking aside, which we may discuss later, is the logistics of giving tarlatamab. But I think from a safety perspective, um, apart from low-grade CRS, this seems pretty manageable.
And I guess the most exciting thing is what I'm showing people on the screen now, which is the overall survival data. I thought this was pretty impressive. Now you have to be really cautious. It's a phase 1 study. It's small numbers of patients. But shows what do you reckon? I mean, on the screen here we see a 12-month overall survival of 80.6%.
Yeah, I mean, I think that says it all, and the curves don't seem to be dropping. I think this is yeah impressive. It is early phase. I think we do need to take it with a bit of caution, but I think this is a highly impressive signal, especially compared to I think the modest benefits that we've seen with the addition of PDL1 anti-PDL1 drugs. So yeah, I think there was a lot of excitement when this data was shown.
It was, you're absolutely right. Sharmistha, so we've got this, we've got quite a bit of grade 3 talk, 4 tox. The presentation said, oh, well, look, it's the same as the contributing drugs, and that's true, but you're now having 4 drugs, so it's quite a lot of tox. But you've got an impressive OS benefit. Same question as before. Would you be using this if it was available in clinic, or do you need some more confirmation beyond a phase 1b study of less than 100 people in each arm?
Yeah. We do need more, I think, to have more data to have this widespread and be able to use it all throughout the UK because of the numbers, because it's an early phase study only.
Yeah.
We're not really used to kind of kicking off and starting opening up clinics and things on such early data and small numbers. But I mean, the shape of these curves, it's the shape. They don't drop at all. So I think this is really, really promising and something we're going to have to make ways to have this available in clinic as time goes on. This is small cell lung cancer, and I don't think
Yeah.
we've ever seen curves of that shape, small cell lung cancer before, extensive stage small cell lung cancer. So
Yeah.
I think this is definitely where we're going, hopefully,
Yeah.
with
I agree.
this.
And obviously we acknowledge that there's a lot of immature data, there's a lot of sensor points around the 12 months, and we're not suggesting these are flat forever, but I guess what we're pointing out is in that period up to 12 months, the curves are not dropping too much. So I think this is really interesting. We definitely need phase 3 data. We definitely need longer follow-up, but I would be watching this very carefully. Um, Now we're going to move on to North Star. North Star is all about local consolidative therapy, or LCT. It's something which we've been looking at a lot. There's a number of studies going on. We have our own UK-based studies. Saron being one of them, HALT being another. This particular study is in EGFR mutated patients. Tell me a little bit, Sharmistha, about North Star and how it ran and the design of the study, which I've got up on the screen at the moment.
So this is a study, as you said, looking at EGFR, patients with an EGFR mutation, a common EGFR mutation, so an exon 19 deletion or an L858R. So no rare EGFR mutations were included in this. And this is not local treatment used on oligoprogression. So this is using consolidative treatment earlier on. So bringing the multimodality approach a little bit earlier on and not waiting for progression, which I thought was really interesting. We want these patients to try and remain on their TKI for as long as possible. We know that they're well tolerated, as we've discussed before. So patients here are having osimertinib, so this third generation TKI, and they're having this for 6 to 12 weeks as almost an induction period. And then they're randomized to either continuing on the osimertinib, as we would standard of care we would do, or we would consider local consolidative therapy. And this could include radiotherapy, surgery, or surgery and radiotherapy. And the primary endpoints here was looking at progression-free survival, so PFS, and we also looked at the secondary endpoints at safety when you're adding in the LCT and overall survival as well. And really looking very closely at the number of different metastatic sites they had and how the patients went on. So thank you. Looking at the demographics and basic characteristics, what we would expect with this group of patients. Now, if we look at the number with greater than 3 metastatic areas, 45, so over 70% of patients had more than 3 metastatic sites at the time of starting the osimertinib.
And just interrupt you there. I mean, that's a really high number. So a lot of the studies so far have limited the number of metastatic sites to no more than 3. And here we've got 70% of patients having more than 3. I mean, that's a very advanced disease by the standards of a LCT study. Is that a fair thing to say?
Definitely. And this is what my first point. This is not looking at disease progression. This is patients who already have a heavy burden of metastatic disease. And we're coming in early. We've got on top of the disease with the osimertinib, with the TKI, and then we're coming in early with consolidative therapy. We're not waiting for 1 or 2 of these to start progressing in the future. So this is an active cancer, and we're starting to use multimodality treatment. I was excited at this.
Yeah.
Looking as well at brain metastases. So a third of patients in the Aussie arm had brain metastases, and just over a third receiving the consolidative therapy as well.
So what was the highlight of the activity for you? I mean, it was PFS was what they decided to measure. We'll come on to second whether that's the right thing to measure. What struck your eye with the results, which I'm showing on the screen now?
So PFS, yeah, we'll talk about that first. PFS, looking at for those who can see the slide, the green line here is the osimertinib plus the local consolidative consolidative treatment, beg your pardon, and the red line is the osimertinib alone. And we can see the median PFS is 25 months, so over 2 years remaining on the osimertinib with the addition of either surgery or radiotherapy or both, in comparison to 17 months on the Aussie alone, which is what we would expect with patients on osimertinib alone. So they're over 2 years with the median PFS, and that gives us a hazard ratio of 0.66. Excellent, in my view.
The progression-free survival, now, I guess one issue is that if you're irradiating or in fact surgically removing, because surgery was quite common, all the bits you can see, is progression-free survival a good thing to measure? Because if you just zap something, it's not going to progress very much. Well, what do you think about progression-free survival as the best endpoint for this study?
It's an interesting endpoint. You could have looked at, different things in order, but we have to remember that if we're wanting this to be our standard of care, having osimertinib or having a TKI, and then adding in different treatments along the way, you're wanting to measure them with other trials, in comparator trials, whether you're adding in, for example, an ADC, so you're going to look at PFS to make them more I suppose, comparable going forward. So I think that's probably why it's still relevant to look at and discuss as we are today.
And I think the trouble with overall survival is it takes too long to get the answer. I wonder if you could have used an additional endpoint like, I know, appearance of new metastases, because I think if you don't have an overall survival, then one has to be a little bit careful. It's a really heterogeneous population here. There's a lot of people with malignant effusions, multiple sites of disease. Shobes, is this going to change your practice? If you had the magic wand, you could do whatever LCT you wanted. Are you convinced by this, or do you think we should be selecting our patients a bit more carefully?
A bit of both. I mean, one aspect is I think we do a little bit of this in practice anyway. If you've got somebody with low volume disease and there's not much residual left, I would reach out to my colleagues, probably not surgically, but I think that, the number of lobectomies and things was quite eye-opening in this. But definitely radiotherapy, SRS, SABR, these are things that I would be reaching out for. But I think what was interesting, it really showed that those patients with the higher metastases didn't do as well compared to those with lower, the less than 3. So I think this is highly patient selective, and there wasn't that granular detail in this. I'd love to know where were the sites of disease, with those with the greater than 3 metastases, well, how many were treated to the point where all sites were actually eradicated, and what modalities or investigations were actually done to look at what sites were left. So I think there's a lot missing here, but I think this is definitely a strategy most of us probably do employ anyway. But it's such a heterogeneous group that it's so I think hats off that they've actually performed this study.
Yeah.
One point, I mean, I'm more used to, if you kind of imagine 3 groups of patients, so those with a disease, and then we would maybe use treatment as in HALT on oligoprogression. Then you have the patients in whom, as you mentioned, Shobhit, low burden of disease, and then you're using radiotherapy perhaps rather than surgery. But this is different. This is heavy burden of metastatic disease and then coming in with consolidative treatment, which is not something we're really doing a lot of, I don't think, as much as the other 2 groups of patients, as in one the oligoprogression and one with the low volume of disease. So yeah, I agree. I mean, 30%, over a third of patients went on to have surgery, which is something I don't know how we'd be sitting in MDM to persuade our thoracic surgeons with these patients with a heavy burden of metastatic disease and asking them for surgery. And in the conference itself, this was raised that there wasn't a lot of detail, especially, I mean, patients had pleural effusions, for example, and areas that are quite difficult to control, and they were having surgery or radiotherapy. So, and there will be more data coming out, and they will give us more kind of granular data that I think will help us a little bit more. But for the first, just for the beginnings, I think it gives us a lot of food for thought.
Yeah,
I think
I agree.
Yeah.
And I think the other thing is we should just remind ourselves that if all the areas weren't covered by the local consolidative therapy, the benefit was lost. So I think one message is if you're going to do it, you've got to encompass everything. So I agree. I don't think it changes practice today. And we really look forward to Holt and Saron, and we look forward to a bit more granularity, as people say nowadays. So Shobes, I'm going to ask you to talk about MDT Bridge, which is a challenge because this is a complicated study. And this is the last of our big 5. MDT Bridge got quite a bit of kind of press beforehand, and it's looking really at patients with borderline resectable disease in the locally advanced setting and seeing how we might manage these patients in a phase 2 study. I've got the design up on the screen at the moment. Can you explain to us a little bit what they were trying to show and how they did their study?
I'll do my best. So this is as you said, this is a phase 2 non-randomized study, and I think it's almost trying to look at an approach in terms of combining our modalities of perioperative and the Pacific data post chemo rad, and trying to maximize the benefit for patients coming through our MDTs with early or operable or potentially operable disease. So patients had to were stage 2B to 3B as per version 8 of staging, non-small cell, EGFR and ALK wild type, as we would expect in any kind of perioperative clinical study eligibility. So patients were then deemed either resectable upfront or borderline resectable. Patients then received 2 cycles of platinum chemotherapy plus durvalumab, and were then restaged and rediscussed in their MDT. The point of this was really then to look at those that were deemed resectable up front. Are they still resectable? And if they are, they follow down the pathway. We'll talk about that next step. Those that were borderline resectable, have they been converted now to resectable, or do they remain down the unresectable route? In which case they would go down a radical chemoradiotherapy route. So those that were still deemed resectable had another 1 to 2 cycles of neoadjuvant treatment before surgery, and then adjuvant consolidative treatment as per kind of perioperative approach. Same for those that had their chemoradiotherapy. They then went down kind of the Pacific pathway of adjuvant durvalumab.
That's beautifully explained. Well done. And I think that's very impressive. And I think it is complicated. There's a very nice slide which I put up on the screen now, just trying to kind of see what happened to patients. Are you able to decipher this for us?
Again, I'll do my best. So I think the key take home from this is those that were resectable up front, the vast majority of these still remained resectable, completed their neoadjuvant chemotherapy and had surgery. I think the really interesting group here, but again, I'm sure we will discuss the issue of what was deemed as borderline resectable, is that the vast majority, I think about 80%, well, 23 out of 28 patients who were deemed borderline resectable. So I think by true definition, in our own MDTs in this current day and age, we would not be going down a surgical route for these patients. By this strict definition. The vast majority of these were deemed at that second MDT to be resectable and then went down a surgical route. So those, I think the key thing is that conversion, if we can call it that, to resectability. But I think also the really, I think, impressive aspect of this is over 90% of patients, regardless of whether it was surgery or definitive chemoradiotherapy, went down a definitive radical curative pathway. So really by this kind of tight MDT review, whether patients were deemed, the vast majority went down the resected route, but even those that didn't were then salvaged by by going down the concurrent chemo-rad route.
Yeah, I think absolutely right. 82% was that patients who were deemed to be resectable, having been borderline beforehand. Yeah, it's really interesting, isn't it? And the picture there explains it quite nicely. We then get onto the PCR rate, the pathological response rate, complete response rate, 27.6%. What's your thinking on the efficacy? I know it wasn't a full data set, but what's your thinking on that?
Yeah, I think for me, this just it kind of matches what we've seen with every PCR, from the neoadjuvant study to all the perioperative studies. We're always at this kind of 20-ish percentage. So I think this is reassuring. I think the vast majority are not resections. So clearly within this study, which I think was done predominantly in academic centres, there was, I think the decision making was appropriate in terms of those that went down that surgical route, based on what we can see in terms of PCR, as well as the rate of R0 resections.
So it's really interesting this. I mean, I think one thing I noted was that actually the borderline resectable patients were only a third of the patients included in this. So I don't quite know why they mixed them all together. But it does suggest that if you have a borderline resectable patient, that maybe we should be getting on with our neoadjuvant treatment and seeing what's going, because you've got an 82% chance of them having surgery. Sharmistha, do you see it that way? Does this convince you that we should be doing that? Shobhit's raised the thorny issue of what really is borderline resectable. What's your take on all this?
This is the thing. I think this brought home to me how essential our MDT is, and how we really need to, the definition of resectable, borderline resectable, these need to be, clear, well defined, and we need to be up for a good discussion. I think we need to be quite keen. So yeah, those patients who were borderline resectable and then became resectable, and then, only, I think the ones who were borderline resectable and who remained who then went on to unresectable, weren't even well enough to, or didn't have chemo RT. So it suggests that are we missing a few patients there who could then go on and have a pathological complete response?
Yeah.
So for me, it certainly just thought, wow, I really need to be making sure that we are discussing these patients. We had a good MDT discussions. Do we bring in an extra discussion for those who are maybe borderline resectable to think about offering them chemo IO? Yeah, a lot of
I think that's right.
encouragement
And
on
I
that.
think the other but thing to note about this, it's done in some very, very specialized centers, sorry. And if that is your bread and butter, that's all you do all day long, that's fine. But how applicable is this to the real world? There was interesting data suggesting that if you have gone and had neoadjuvant chemoimmuno, if you do remain unresectable and you go on to have the chemo rad, some safety data was shown saying it doesn't appear to make the chemo rad any more dangerous. So I guess that might reassure. I think we've got to be careful that we don't end up giving neoadjuvant treatment to anyone who walks through the door. But it does raise exactly as you say, Sharmistha, that really interesting concept of they're borderline resectable, and they really might be. Perhaps we shouldn't just not do that and assume they can't have surgery. Maybe we should be looking at the neoadjuvant treatment after all.
I just feel
So
we
it's
need
phase
that
two study.
granular. Yeah, I
Sorry.
was just going to say, I think just need that granular detail in terms of. I know that I think the borderline resectables were down to T4 tumors, but I'm sure these patients were in our perioperative trials.
Yeah.
And it's I think just stretching that definition and really understanding what makes something borderline as opposed to completely unresectable.
Yeah. I agree. Right, that's our big five. So just to remind people on the screen, at the moment we discussed OptiTrop, which is the TROP2 ADC and second line EGFR mutated lung cancer, showing really encouraging data and very significant clinical activity. We discussed Harmony 6, which is a PD-1 VEGF bispecific monoclonal, which would appear to be better than standard immunotherapy when combined with chemo in squamous cell tumors in the first line setting. Very exciting. We saw the early phase Delphi 303 with tarlatamab added to chemoimmuno with a remarkable overall survival benefit and lots of caveats about it's a phase one study and it's small numbers, but this really is one to watch. And we hope that that benefit will be shown in the phase three studies. We talked about local consolidative therapy in EGFR mutated lung cancer with North Star. And it was found if you add that in, you significantly prolong progression-free survival. Some caveats about the very heterogeneous patient group, but it does appear to be a way of keeping people on your osimertinib for longer. And then finally, we just discussed MDT Bridge, a phase two study looking at unresectable borderline resectable disease. Can you make it resectable after chemoimmunotherapy? Yes, you can in a large number of patients. Maybe not quite the right thing to do yet, but a really fascinating study. So having done the top five, we're going to go on to the quick five. So I think, Sharmistha, you're first up. Now, I slightly cheated. I put the FLAURA2 overall survival data in. That actually came out in World Lung. But we're going to sneak that one in first. So here we go on the screen now. You'll see the overall survival for FLAURA2. Sharmistha, just remind us what that regimen is. Most of us are using it. And tell us how much of at all the overall survival data impacted on your view of this regimen.
Thanks, Tom. So, FLAURA2 is osimertinib with chemotherapy for patients harboring with a lung cancer harboring an EGFR mutation. And actually, this was NICE approved and reimbursed in the UK in May of this year. So most of us will probably have used this if we've seen EGFR patients in our clinic over the summer anyway, be able to use this regimen. So this is osimertinib with the addition of platinum backbone chemotherapy, such as carboplatin pemetrexed. And this was, as you see, was actually at World Lung, but I think it's good that we included it because it was only a month back. And just to kind of confirm where we are we doing the right thing? Where are we? We didn't have the overall survival kind of when this all came out in May and we were able to use it. So if we look here, we could see that the median OS in those patients who had the osimertinib in combination with the chemotherapy was 47.5 months, so almost 4 years really, with the addition of chemotherapy in comparison to just Osi alone. So certainly for me, this kind of confirmed that this was, I'm doing the right thing. I think there is a reason for doing this, having used it for a few months already in my clinical practice, and something that maybe if patients were thinking and asking, oh, the extra toxicity and any questions about it, this was certainly a good reassurance for me from that point of view.
And the comparator is Mariposa, which is lazertinib and amivantamab, remarkably similar overall survivals, both in the control arm and the experimental arm. Both have this crossover. If you look at the screen at the moment, if you have access to that, you'll see that the control arm of osimertinib alone actually did a bit better in overall survival in the first 12 to 18 months. And it's not entirely clear why that is, but presumably it's to do with some of the additional toxicity of the combination arm. But I think this, I agree with you, Sharmistha. I think this reaffirms what we probably thought it was going to show. And FLAURA2 is something that we can use at the moment. So the next one we're going to move on to, and I'm going to ask Shobhit you to have a look at this one. The first of our HER2 targeting drug abstracts, and this is BMION 1, presented by our very own Sanjay Popat, erstwhile chair of BTOG and general all-round hero. So zongertinib, this is in HER2 mutated lung cancer in treatment-naive patients. Data up on the screen for activity. What's your thoughts on what's in front of you?
Yeah, I mean, I think this is what we like to see in terms of TKI response rates as waterfall plot. I mean, it's really showing an ORR here, 77%, and durable responses as well. So this is, it is what it is. I think that we'll talk about the other HER2 TKI as well, but the zongertinib, in terms of efficacy, is definitely showing potency, but also the fact that it spares that EGFR component, I think also really helps from the safety perspective as well from this agent. But yeah, definitely, I think in terms of efficacy wise for treatment naive patients, this is impressive data. And bearing in mind that HER2 mutated lung cancer, it's a very aggressive disease, carries very poor prognosis, and these patients tend not to respond as well to our chemo IO treatment options.
Yeah, I think it's a very fair point. You can see on the figure at the moment, it mentions that in the kind of purple dots, the bottom YVMA, that's a particular mutation type you get with HER2, and it's the commonest one you see. But actually, the activity appears to be kind of irrespective of that. So that's encouraging. And I think there are other agents available. There is the trastuzumab deruxtecan, which we don't have access to in the UK. So actually, we don't have access to any drugs against HER2. And I think what's interesting about this zongertinib data is that this is clearly a very active drug, kind of the same response rate we get with osimertinib, and that's our kind of gold standard, isn't it? So the adverse events, there were some adverse events, predictably, and there was some diarrhea, but perhaps more favorable than the other agent, which Sharmistha, I'm going to get you to talk about, which is a SOHO-01 study, which was presented. Now, many different cohorts of this phase 1 study were presented by Xuning Li at ESMO. What I pulled out on the screen for people at the moment is the same sort of patient group as was shown in BMION. These are treatment naive. What's your view on this response rate and activity, and how do you look at it compared to the BMION study?
So this is cevabertinib, which is a HER2 TKI. And this actually is active with HER2 missense mutations, HER2 insertions, and also thought to have activity in secondary resistance mechanisms as well. So perhaps a bit different to the zongertinib. So this is cevabertinib. And yes, we discussed 3 cohorts actually at ESMO. And this one is cohort F, which is those patients who have never had any treatment. So they're completely treatment naive. And we can see here as there was a 71% ORR in this treatment, in this cohort of patients. And actually, the other 2 cohorts, which were also discussed, were those who'd had a previous HER2 treatment prior to the cevabertinib, and also patients who'd had previous chemo IO or IO on its own, and then had the cevabertinib. And this cohort here were the patients who did the best. So basically, if you're HER2 naive, you're going to do well on this medication.
Yeah, I guess not surprising. Now, one thing about this particular agent, sevabertinib, is that it was actually originally designed as an EGFR targeting agent, and then was found to have a lot of activity against HER2, and it is hitting some EGFR. You do have higher diarrhea rates with this agent than you do with zongertinib, but I think it's fair to say they are both much better tolerated than certainly previous attempts at HER2 targeting drugs. Question for both of you. If these drugs are available, do you think this is a stage shift in how we treat HER2? Do you think these will allow HER2 TKIs to enter the first line in due course? Do you want to go, Shobes?
Yeah, I mean, I think we talked about the need for confirmatory studies and trials, and I think there comes a point where rare alterations or mutations, I think that the data is convincing enough, in all honesty, and
Yeah,
these are
yeah.
drugs that I think we should I'd be keen to be reaching out for these if I had a patient in clinic tomorrow.
Yeah, it's a
Real
great
quick,
point. Shamisa, do you think we need a phase three? I mean, these are clearly highly active drugs. Do we need to undertake a very expensive randomized phase three study, which will tell us what we know already, and will put half the patients at a disadvantage because they won't get the drug?
Be good to know. But if you remember with ALK, we were able to get access to crizotinib just on early phase data for
Yeah,
that reason. These are rare cancers, and we're trying to move along here in the world of oncology. So um, we probably have enough to know that this is going to be. We understand more about oncology and in the basic science. So I think it would be hard to push this to one side and start going down a long trial and then have access to this in 3 or 4 years' time. It'd be
yeah.
a difficult thing to do.
yeah,
I
I
mean, I
think the
think this is a game changer. I think these revolutionized first line treatment of HER2. It's a rare tumor type, but I think all change. Abstract number four is the Lucian study. Now I can't remember who's discussing this one. I slightly lost track. I think it might be Sharmistha. Are you doing this one, or is it you, Shobes?
is it you, Sharmistha?
Yeah,
Is it?
either of us, yes. So this was looking at pembrolizumab and chemotherapy versus chemotherapy alone. Sorry, immunotherapy alone, IO, for specifically those patients with the non-small cell lung cancer with the tumors with a more than 50% expression of PD-L1. So we often add chemotherapy to immunotherapy in those patients who have a high burden of metastatic disease if we want a quick response. So we can give IO alone, but we often add chemo with that. So this was a Dutch trial, and there was there were 8 Dutch sites, and there was 84 patients that they started off with. I think 70 odd patients were randomized to receive either chemo IO or IO alone. And really looking at what is the benefit of this addition of chemotherapy that we tend to do. And actually, we looked at time points at 6 weeks and then at 12 weeks. And we can see here the survival curves, Kaplan-Meiers, where you can see that there's not really much difference at all in PFS or OS. And this trial was actually stopped early due to fertility. So just telling us that not really much difference that we're seeing when we add in chemotherapy to these patients when they've got a high PD-L1. We didn't get much data between whether, the 50 to 70s versus the 70s to 100. There was not enough detail on that, but enough just to kind of maybe think twice or have a few questions about what we're doing for these patients.
Yeah, I agree. I think it's a great study. It's one of the ones you kind of wish you'd organized yourself. In that PDL1 high population, is chemo immuno better than immuno alone? And perhaps not. And I think it's an important negative result. I agree completely. I wish they'd stratified according to PDL1 really high because there's a massive difference between PDL1 55% and PDL1 95%. I don't think this means we shouldn't be using chemo immuno if someone's got a PDL1 lowish, 55, 60%. But I think it helps inform us on our options. So an important one to look at. And the last one shows you get to talk about the happy study. This was the long-term final, I think, OS survival readout from the ALEX study of first-line alectinib. In fact, I went through this with a patient in clinic today. The picture's up on the screen at the moment. Tell us about this amazing response and this amazing drug.
Yeah, so this has been a long time coming and for the right reasons. So Alex study, this was, I think, first reported back, I think 2017, 2018. This was the phase 3 for our ALK positive patients, randomizing between what was the standard of care crizotinib against alectinib. And we had already changed practice based on the PFS data, which was around 34, 35 months for alectinib, around 10 months for crizotinib. And really, alectinib or second generation ALK inhibitors had become the standard of care. But it is very, very pleasing to see the overall survival data. So for the alectinib arm, we're at 81, staggering, should I say, 81.1 months versus 54.2 months. It wasn't statistically significant, so it's a very meaningful 2-year benefit in terms of overall survival. Hazard ratio 0.78 with the confidence interval spanning over 1. But clearly, this is, I think, like you say, practice affirming, I think reassuring for our outpatients what kind of outcomes we can expect to achieve for new diagnosis patients with such a devastating diagnosis. And also bearing in mind that, I think in Alex, about 40% of patients had brain mets at baseline. So again, showing that hasn't had a detriment here.
Absolutely. I mean, it's great data, isn't it? And I think it's confirms what we know already, but we love long-term survival data when it's this good. So that's our last one. So those are our quick five of FLORA 2, the overall survival benefit. You can see the summary on the screen now. Of first-line chemo and Aussie, the BEAMION and SOHO studies, both HER2 targeting drugs, which are both very active, and I would hope we will see them in the first line use routinely. And as you both rightly said, we need access. The Lucian study, a really good academic study, kind of redefining first-line chemo, immuno versus immuno and PD-L1 high, and no difference between the two. And although that may be seen as a negative, I think it's an important negative to know. And then that remarkable final OS data, survival data for alectinib. So I hope that's been helpful. I hope the new format has worked out. I'd really like to thank Shobhit and Sharmistha for giving up their time for this. If you are listening to this on a podcast and you're wondering quite how on earth you get the pictures, you might want to reevaluate where you get your podcasts from because the images are there. If you're listening to this on the podcast and you want to see the whole webinar, you can do that on the BTOG webpage by becoming a member, which is free. And then all these wonderful educational resources are available for you. So thank you, Shobes, thank you, Sharmistha, and thank you all for dialing into this.
Thanks, Tom.
Thank you.